All right, so Dr. Grant Stucki here. Everyday Oral Surgery Podcast, UCLA Dental School, UIC Oral Surgery Residency. And yeah, speaking of podcasts, we finally connected here after how many months have we been?
Several attempts. It's mostly my fault. My life's way too busy. I'm sorry.
Oh no, it's been like a game of tennis or ping pong back and forth with all this. But
Yeah.
yeah, so word on the street is you have the number one oral surgery podcast. Congratulations.
Thank you. Yeah. I've been doing it for 6 years, and we've done 375 plus episodes. A lot longer than I envisioned it, but I think it's good. I think we hit a lot of great topics, have fantastic guests, a lot of good content related to every aspect of oral surgery, business, clinical stuff. It's all good things. I think is still offering value. So hopefully it's good for the community.
I think you got to keep it going. It's tremendous value. I mean, you have people asking you for more topics all the time, right? So
Yeah, it's a good one.
it's awesome. Actually, what's your personal favorite topic to jump into?
So I'm a bread and butter, mostly oral maxillofacial surgeon. So I mean, I, clinically, I love talking about the usual stuff: extractions, implants, bone grafts, all that type of stuff. I'm also passionate about like building a team and a business and all that type of stuff. So it's all good. Anything in there is good.
So
Yeah.
it all flies. Good,
Yep.
good, good. So I want to try and touch on all those topics today. And I know you're busy, you're still at the office and everything. So I appreciate you taking the time, you know?
Oh yeah, for sure.
Yeah. So right now you're in practice, right? You graduated from UCLA and UIC. How did you like UCLA for dental school? Just to bring it back to the beginning.
UCLA was fantastic. I loved it. It's a 4 year school. It's nice because they offer in-state tuition every year. I came from Utah at the time. Great people. I think UCLA is kind of cool. It attracts really high level people who want to succeed. For better or for worse, like I think the majority of the class wants to specialize. I don't know. There's a lot of what we would term at that time called ourselves gunners, or everyone was a gunner. Gunning for specialty. But I enjoyed it. I liked having other people who had the same similar goals, and it was dental school wasn't a joke. It was like everyone was working hard, and I appreciated that. My dad went to USC, and he did not have a great experience. He went like 20 years before me, but it was very much like a us versus them, and the faculty would. He has a story where he showed him. I think it was a wax up of something. Like a new dental student. How does this wax up look? And the professor threw it on the ground, stepped on it, and said, "That's a bunch of crap," and swore in his face.
What?
That's
Like,
old school stuff. So our professors were not like that. They were very helpful, very like on your side. So I don't. Hopefully none of that exists anymore today. But UCLA was great. Yeah. Residency, and that's probably most people can say the oral surgery residency is not all rainbows and butterflies, and there's lots of high strung attendings that don't take well to people who make mistakes. And so that was trial by fire, and it took me a few months to kind of get my bearings and like say, oh, okay, this is going to be different than dental school. I really have to just step up my game, watch my back, hustle, have thick skin, learn how to take the heat for problems, especially if you're the lead resident on a certain situation. So did you have that experience, or how was it for you?
yeah, same, very same. Watching your back, just trying to day by day, getting through it. Whatever you did was wrong for those certain people. Yeah,
Yeah.
yeah. And
Um,
then you did the 4 year, right?
yep. 4 year at Chicago, Dr. Maloro, Dr. Kolokaitis. A lot of those residents, Tom Schleve, was a co-resident. He's the director of Parkland now. Just so many great residents. I was blessed to have so many good people with me. But yeah, no, it was a good experience. Did you do the 6 year or 4? Or what did you end up doing?
Four, just the four. So I agree with you in the bread and butter work, learning how to, just basically maximize your day, your career. And I bet that's big for you, right? I read somewhere, do you have 6 kids? Is that real?
Yeah, I started residency with two, and then I ended residency with four, and then we had two more after residency. And it makes life exciting to have a big family. It's just takes a lot of energy and money and time.
How did you manage that during residency? My God.
Brutal. I mean, it's brutal for my wife too. She was just so strong. She's a strong woman, and yeah. I mean, I've talked about this on my podcast. Just like to make it through residency with kids, you have to go into it with good expectations and gosh, trying to carve out time. I mean, I went to UIC, which was known to be a quote unquote family friendly program, and most days, I could get home around 6 or 7 p.m. and it was call like where we could be at home at night and run over to the hospital if we needed to. And so I think relatively speaking, it was family friendly. But even then, if I leave at 6 a.m. and I don't go home till 7 p.m., I mean, it's still brutal for a wife to be taking care of little kids all day like that.
Yeah. Yeah. And did she work too, or it was just you during that time?
No, yeah, she stayed home with the kids and just
Yeah.
getting through it. But yeah, no, it's good. My oldest is 18 and she's graduating from high school, going to college. Um, so we got a lot of fun stuff. My youngest is 8. Do you have kids or no?
Hopefully one day. Not yet. Not
Okay,
yet.
okay. Yeah, that's when the real learning starts. I feel like you learn stuff in oral surgery, and then it's like those things of life, like marriage. If you get married, it's like, man, the learning curve was so steep there. I was like, my wife is just very patient, but yeah, I feel like those big monumental things you do, marriage, having kids, probably one would be getting a partner, and in business. All those things are just big, huge learning curves. So yeah, man. But residency is one of those things we've all experienced and like bonds us all together. Is just to
Mm.
make it through residency, you have to have grit, man, serious grit.
That's right. That's right. You mentioned a partner. You said partner in practice as well as like in marriage. You meant, right? You were saying about your practice.
Exactly. Yeah.
Now, why don't we hop into there, right? Because I have plenty of questions for residency, but you mentioned the partner, and I think that's very important. Like, what do you look for? Did you have a job before you're in your job now? Are you a solo owner, or do you have one partner, multiple partners?
Yeah, I've been through many job scenarios. Like when I came out of school, I was just an associate working for kind of a smaller, I guess you could call it a DSO group that was owned by a single guy, and
Mm.
did that for a few years, and then joined a larger DSO as an independent contractor. Then I bought a practice in Utah, worked that for a year or two. Currently, I'm kind of working mostly for a large DSO, Pacific Dental. And my brother is kind of my partner in that venture, and we're always exploring different options. But I don't know. I think it's good to experience a lot of different things. You know, I've been a W-2 and IC practice owner. Once you do all these various things, you kind of see the benefits of each thing, at least from a financial perspective and a decision making perspective.
Yeah.
But yeah, it's tough to know, especially right out of school or like as a chief resident, like to know what's going to be the best, real scenario for you to get into. Because so many guys, I feel like the stories are endless of people who join a practice and are promised all these things, and it just doesn't pan out. And it's like, oh, we promised them all these patients. You get there, it's slow. We promise you to become a partner after X amount of years, and they're delaying it.
Yeah.
Stuff like that just drives me nuts, man. When I hear these stories.
That happened to you?
Luckily, I mean, I went straight into just being paid, like how I knew I would be paid, like with commission or a salary and a bonus, and that was fine for a couple of years. But I resisted becoming like an associate with this buy-in track, because I would heard that was the traditional model when I was graduating, and I just didn't. That wasn't for me. I didn't like that being the low man on the totem pole and kind of being at someone else's mercy in their practice, to know about, okay, well, if you work for me for 2 to 5 years, then I'll let you be a partner. And the details of that are like very murky.
Yeah.
I just
Vague.
didn't want to put myself in that position. So I was like, nope, not going to do that. So, I mean, I like the good thing about being an independent contractor and like what I do now, at least for the present, is, it's commission. So you get paid for whatever you do. And I mean, I've negotiated a very reasonable commission, that type of thing. It's independent contractor, so you're paid pre-tax. So I have much more flexibility with what I can do to shelter my money from a tax perspective.
Hmm.
I have other kind of associates underneath my entity, and so that's been good. But gosh, it's tough. Even now, I look back and say, did I make the right decision? It's hard to know. How about you? What are your thoughts on that? Do you have any life experience with all that stuff?
Not as much as you, obviously. A little bit. But did you? What happened to the Utah practice? Are you still partners with your brother on that, or is that it's like together, or are you just gone now?
That I sold. Yeah, yeah, we sold that. That I actually owe. I own that with like a few years ago. That was with my father, who was a general
Hmm.
dentist, and so he sold me. It was a general dentist slash like multi specialty office, and so I bought that from him during his last few years of like preparing to retire. And I was commuting there from the Colorado area, so I would go there multiple times a month to Utah, and we were pondering moving there and kind of doing that long term. But when I decided I was going to stick it in Denver, it's just long term to do that for more than a few years. It wasn't my jam to commute.
Mm.
And my dad was retiring, and so I was like, yeah, gosh, I don't know what this would look like if he left, and do I want to own this? Just kind of as someone who only is there, a few times a month. So I ended up selling it, and that I think was a good decision.
Why? Why was it a good decision?
Well, I just think when you are owning a practice, especially if it's in a smaller town, which it was in Utah, very much like a mom and pop feel, and like the clientele really wants a very integrated person in the community to see them.
Mm.
It's very tough to kind of only be there a few times a month and then hire like a guy to come in who the community doesn't know, and to expect patients to trust that person. And I mean, we tried it over the years, and it was just very tough. So I think it's a whole different ballgame working in a community like that versus like a big city. Let's say you're in San Francisco or in the middle of Denver, New York. Where people, probably the patients, don't expect to know who your surgeon is and don't have any personal relationship there. It's
Ah.
and so they can show up and maybe you could say, oh, well, the dentist you used to see is gone now, but we got a new associate. He's great. And they'll be like, okay. But when you're in a small community and that happens, they'll be like, oh, well, I'm going to go to my other neighbor who's a dentist as well. Like I know that guy. So it's kind of some just weird dynamics that don't exist in a big city.
I see. And it's hard to see when you're commuting and they wanted someone who's got feet on the ground. And sure, you were the son of who owned the place, but they didn't get to
Right.
know you as well being in the community. That makes total sense. And then,
Yeah.
and so that's gone. What about you? What does your brother do? You said you have a project with your brother?
Yeah, so he's an oral maxillofacial surgeon. He graduated last year. He's works with me now here. We do so he works as well for Pacific Dental, and we also work together in the hospital doing OR cases and things like that. So it's cool. It's cool to have him, and we're constantly brainstorming new ideas. He works with me on the podcast, and he like me is a creator, and so it's just like two creative minds working together. At some point, we'll conquer the world, man. Hopefully, we can do it
Yeah.
soon. But it's
I
fun to have
love
a
that.
partner in crime.
I love that.
Yeah.
So you're both in Denver too. I mean, that's great. So you got family together. He's also an OMFS. How about that? I did
Yep.
not know that. I did not realize that.
Yeah, it's super fun. He's got 4 kids, you know, that are little, and my kids sometimes babysit his kids, and it's just fun to go out to lunch together. he calls me at the end of his day and tells me the rundown of what happened with all his patients. And it's like, as an oral surgeon, when you go home, let's say if you're married, there's only so much your wife can tolerate about you talking about your patients and your career. She'll be like, okay, I get it. A lot of people in pain. Can you take the trash out now? That,
You hold the
God bless. Yeah, God bless these women that put up with us. But if you have a good friend, who's an oral surgeon or a brother or someone, it's a different conversation because you can really get into the meat of clinically what's going on and the whole scenario.
yeah.
So that's been fun for me to have him there.
Is he one of
You,
the? Because you said he just graduated. He's one of like the quote unquote associates that works with you, or same level. I would imagine that you're kind of further up in Pacific.
yeah, yeah, kind of the same. Yeah, exactly. He's kind of an associate, independent contractor as well in our group, and he does really well. He went to Case Western and loved Case Western. I think, as far as I know, that's the only 5-year program,
Yeah.
but it was a good one. So it's great. I've been in practice since 2013, so that I think I'm out almost 13 years now. But it's fun to have someone like that who kind of revives you for the joy of oral surgery. Because after many years, sometimes you can lose a little bit of steam and start focusing on the negative. And he just is pure passion, man. He loves it. Even the bad patients, he's like, "This is so great." So it inspires me.
Let him get a couple Google reviews on there, and we'll see if it's still so great. No, no, that's good. It's all learning experience, right?
Yeah, for
And then
sure.
you said you're independent contractors, so I'm guessing 1099s, and you're at that. Is that a general dentist office? Is it just a specialty office, or only oral surgery? And you guys are in the same office or different offices? I'm just trying to get a picture of the layout.
Yeah, so it's like a multi-specialty office. So they have general dentists, and they have ortho, pedo, oral surgery, perio, pretty much all the specialties, endo,
Wow.
in one large office. And my group, there's me, my brother, and then there's 3 others, so there's 5 of us. We cover what, probably 33 offices, something like that together, and they're all these multi-specialty offices.
Hmm.
So yeah, and it's one surgeon per office. So usually it's not working with another surgeon. But the good part of that is you're going in there, the general dentist is there. Sometimes and usually the orthodontist and the pediatric dentist are there. The beauty of that is, let's say you get a referral that's confusing or doesn't make any sense. You just walk down the hall.
Yeah.
Hey man, could you look at this with me? Let's figure this out right now. There's nothing worse than getting some ortho referral. You call the orthodontist on a Friday and, oh yeah, he's in Jamaica, for the next month. It's just it's so hard to make decisions quickly when you're not in the same office. Goods and bads of both parts.
Ah, that's fun though. I didn't know that Pacific had multi-specialty offices like that. That is great. Very
Yeah.
advantageous to get things done that day. And then, so you're covering multiple offices. How many days a week do you work?
I do, 3 to 4 days a week. The other guys in our group do 5. But Pacific's a good. They're very flexible. You can set your hours. I take my kids to school. Usually, I start at 9. I'm done most days by 2 or 3 p.m.
Wow.
Yeah, it's a nice gig. And then if we have OR cases, we'll do those after our day. And we have a great flexible hospital next to us that lets us go whenever, pretty much we want. So it's a good gig. Yeah, it's definitely conducive to family lifestyle. I've had a friend on the podcast who's here in Denver, Aaron Liddell. He's just the man here in Denver when it comes to just volume of big surgeries, and so he is kind of who we would refer to, if we ever get in trouble with anything. But it's good to have a friend like that too in your community. If you are a bread and butter oral surgeon, to have someone who you can bounce off ideas or potentially do a bigger case with that you need help with.
Mm.
Yeah. And the podcast has helped with that because honestly, that's put me in touch with so many people. That was one of my main goals, is just, what do you call it? Connecting and and meeting people. I think too often, in our community, there's too much siloing and people getting competitive with one another. And
Mm.
I've always thought it's more helpful to know each other and be friends than it is to be enemies. And there's just enough patience for all of us. So I don't understand why there's sometimes just bitter rivalries going on. But luckily, it's a good feeling here in Denver. Most of the guys get along well. We talk to each other. It's a great camaraderie. So it's pretty cool.
Oh, that is great. 3 to
Yeah.
4 days a week, and then like 9 to 3 ish is that's an. I don't think I've ever heard of that before. That's an outstanding week. Oh my goodness.
Yeah. Well, I mean, I'm 46 years old, man, with six kids. So six kids adds like 20 years on your life. So I'm already 66 if you think about
Well, go. You don't look 66, so you're plenty. You're fine there.
it.
That's true. The 6 kids, yeah. So I'm sure, like, yeah. I mean, that gives you some leeway somehow because you're not working weekends either. It's just weekdays, and then you have time to spend with them and the wife.
Yeah. And this group is good too because usually, I could work 3 or 4 days a week, or I could take all my days and bunch them into one week, and then like I'll just take a week off per month and work 5 days the other weeks, and we'll go on vacation for a week. So it's great. We travel a lot, as a family. We go, so going to warm places like Florida is a big thing for us. Um, just getting your kids out. We're active in our community and the church we go to, so it's fun. There's just tons to do. My kids are big sports players, so literally when I get home, it's like I chauffeur kids around until 10 p.m. at night.
Oh,
Basketball, volleyball, lacrosse. I mean, it just goes on and on. Gymnastics. It's ridiculous, man.
that is a lot. That's a long
Yes.
week. No, so but you're a family man. That's nice that Pacific's able to get you to that position. Do you see other people? Because also, I'm noticing a lot of spots at DSOs where it's like once the partners, quote unquote, the people who sell out to them or the spots right under them kind of get filled up, the younger and newer associates, it's kind of hard to find such a lenient or really advantageous position for family. I know like some DSOs out here, it's like you want to start, well, you're going to be working 6 days a week and taking call and stuff. And it's like, okay,
Hmm.
great. The money's going to be fine, but the family time might not be. I
Yeah.
don't know if it's similar to your experiences or.
Yeah, that sounds pretty similar. If you were to join like a small group where you're the associate kind of leading the partnership is, yeah, like 5 days a week plus taking call and potentially more work. But yeah, I don't know. Like, I think most DSO opportunities I would think are flexible, maybe.
Hmm.
Pacific Pacific doesn't take Medicaid, so it's not like a real high volume scenario. I've been in a group like that where it was high volume and you're there, from whatever, like 7 a.m. to 7 p.m., just pounding through patients and consults and over and over and over. That just wasn't my jam. But no, so the beauty of what this model that I'm in is that the general dentists, we call them the GPs, they're like really well trained to work up the patients. So they'll see the patients, and say, oh, hey, for example, you need your wisdom teeth out. Here's the reasons why. Dr. Stucki's excellent. They'll message me, hey, do you agree with this? To take these out. Here's the patient's issues. And if the patient has questions, sometimes it's they call me on the phone, they text me. If they want to do a consult, we do one ahead of time. But most patients just want to do a consult and treatment the same day because the dentists have prepped them so well. It's in the same office. I've been working with these dentists for years. And so that just streamlines it and kind of allows you to do more, per a smaller amount of time, I think, because they're helping so much. That's my guess. But no, it's great. I mean, it's a good experience. With that said, they do their best to tee up patients. But if I see a patient that's like same day consult and treat, but they do have an illness, let's say that wasn't properly worked up, we'll say, hey, let's take a break and let's do a med consult. Let's do that. Let's schedule you for next time. So there's certainly that flexibility, but like 80 to 90% of the time, it's it's such a well-oiled machine to set patients up, and they kind of know how to do that and what we're looking for, and the way we communicate is really effective. Certainly different than a practice where you would do an individual consult appointment for every single treatment. I've done practices like that, and it's good. It's thorough. You don't. There's probably maybe potentially fewer things slip through the crack, but it's also, I mean, much more costly to the patient to have to go twice to an office. And oftentimes you'll see him once and then you see him, whatever, weeks to a month or two later, and they've forgotten everything you said. So you have to reiterate everything in the consult again. It's like, I don't know. So it works well for us. What has your scenario been like? Do you do consult to treat, like same day stuff, or do you always consult first?
If it's more complicated, definitely a consult first. And my rule is for sedations, if a patient wants sedation, I absolutely 100% need a consult before. Otherwise, other things, yeah, we could do them same day. I don't see any issue with that. If it's not too complicated, medical history is pretty
Yeah.
straightforward. Cases like, yeah, yeah.
Yeah, that makes sense. Yeah, for sure. Yeah, anesthesia for sure. I mean, that's a hot topic. It's one that we've discussed on the podcast with so many anesthesiologists, dental anesthesiologists, oral surgeons. I mean, that's something we've all got to be like on our A game, like that cannot have um, mistakes. We have to be super, super dialed in on that one. We've talked about like the Swiss cheese model, where
Mm.
Swiss cheeses line up for a catastrophic error to happen. And so I feel like if you have good systems, a good timeout, a good like team that's checking for all these things, it's extremely unlikely to have things slip through multiple layers of protection.
Mm-hmm.
I don't know. What are your thoughts on that?
Yeah, I think your team a lot of times what it comes down to is the team. And yeah, there's a lot of discussions on the anesthesiology discussion as far as like, dual provider and anesthesia provider as well. That can be it's a lot.
Yeah.
It's a lot. But you do a separate consult for those procedures as well, or you just all the time unless they need medical history clearance or something?
Yeah, I would say the majority of young, healthy people are GPs have worked them up, and we've messaged them and or I've called them ahead of time to answer any questions. But certainly there's a percent that want to be seen. Certainly anyone has a complex medical history at all, we would see, individually for a consult. But we do some consult to treat, like when they come fasting and they're all preparing to do it, and that's
Hmm.
works mostly for the young, healthy teenager type thing.
Yeah. No, this
Yeah,
is this is a good topic to get into though. So, as far as
yeah.
sedations go, do you obviously have all your monitors and everything? What's your cocktail like? What do you give them to kind of get them into a nice plane? What's your go to?
Yeah, I think I do the pretty standard stuff. Versed, usually some ketamine, propofol. I've done that for years, like first 10 years of my practice. Lately, I've been using some fentanyl. I was trained using fentanyl, but we do, yeah, mostly that. I think a usual patient will get around 5 to 7 milligrams of Versed, 20 to 25 of ketamine, probably like 50 to 75 of pro, and then maybe 50 mics of fentanyl is like a typical thirds case.
Yeah. Yeah.
Nothing too much. I mean, and the procedures are short, as you know, they try to keep the actual procedure time to 8 to 15 minutes, assuming it's a routine thirds case. Something
Eight
I've talked.
minutes. You said eight, like eight, all four thirds impacted in 8 minutes.
Oh yeah, yeah. It's like, yeah, we do pretty quick, small incisions. I have my assistants handing me the instruments, kind of like, I feel like it's kind of like NASCAR where we're all working together.
How many assistants do you get for like a sedation case?
I mean, I'll always have at least two in the room with me. We try to have three. Every day I have usually five that are with me, just prepping patients and assisting and stuff like that.
Yeah. Yeah.
But very well trained. I mean, awesome assistants. It makes a world of difference if you got good people helping you out. Um, But yeah, no, I mean, I've learned all these little tricks and tips over the years of taking out thirds. Um, we've done more PRF, in the last couple of years, like
Hmm.
spin it, take the PRF clot, stick it into the 17 or 32 site. Sometimes a stitch there. Exparel, we sometimes do that, like long-term numbing to just to decrease the amount of narcotic people use. I mean, just a lot of nice add-ons, not maybe essential, but a lot of cool things you can add to a patient's experience.
Yeah, yeah. Are you giving local too, or is that one of your assistants?
No, I do all the local. Yeah, yep, yeah. We do nitrous, local, you know, local plus nitrous plus sedation, whatever it is that patients need. Sometimes, do you ever do like if a patient needs birthday request to have like Halcyon or Valium or something? Do you prescribe that the day before? If they're like so anxious to even get an IV or anything, or do you manage?
I don't do that because I don't know what they're going to do with it. At home and
Yeah,
stats, I don't usually do that personally. You
yeah.
do that? You send it out?
I mean, so we'll do if we have an extremely anxious patient who like has trouble even just coming to the office or getting an IV. I'll usually prescribe 2 tabs of Halcyon and say, take one 30 minutes before, bring the second one to the office. We'll assess and see how you're doing. And if they're still, kind of anxious in the chair, take a second, let them sit there and wait. The downside with that, though, is you do have to have them sign the consent. All that stuff's got to happen before that happens, right?
Right, right.
But it's something you could potentially do. It's more of a headache to orchestrate all that for sure.
Yeah, yeah, yeah. What's your local sequence if you can do it? Like you said, you mentioned Exparel too, so you're giving that at least 20, 25 minutes after you give local, like the lidocaine and stuff. What's your lidocaine sequence prior to say a clean cut bread and butter third molar case?
Yeah, we do 4 to 5 carps Lido, followed by 2 of Marcaine at the beginning. Yeah, and then we'll take all the thirds out, let them
Hmm.
sit there for a while, and then the Exparel, once they're recovering at the end.
Yeah, yeah.
Yeah. Do you have anything different? Do you use Septo or what are you using?
Yeah, I do like about 6 corpules of Lido, and then I either split one. Yeah, then I split one septo between the lower thirds as like local
Yeah,
infiltrations.
that works.
Yeah, I mean, I think that the long lasting one's great. Marcaine's great. Exparel, I would love to use. I just haven't treated the demographic that because it is expensive. But
Yeah,
uh,
for sure.
but it works. Do you use that on upper thirds too, or just lowers?
Yeah, we do all 4 thirds, just a buckle infiltration.
Hmm.
Usually I do 2 to 2.5 cc's or mLs per extraction site. So, like, usually a thirds case would be 10 mLs of Exparel injected in the buccal vestibule
Yeah.
by all areas. Of course, you don't want to block with that because it's very annoying if you were to have a numb lip or tongue, for multiple days. So don't be doing that.
No, definitely not. Whoops.
But we've had good results, and like people, we don't usually prescribe narcotic when we do Exparel, and the majority we'll say, okay, well, we're doing this with the hope you don't need it. If you need it, call us, in a couple days. But the vast majority never call back as far as needing narcotics. So I think that's a win, especially if you can avoid exposing a teenager to whatever hydrocodone or
Hmm.
oxycodone at a young age. But yeah, the material is expensive. You got to keep it refrigerated. You got to have the right syringes, needles. You're supposed to draw it up with a large and inject with a larger bore needle.
Hmm.
Little technical things like that just to make it effective.
Yeah, yeah. You mentioned some little tricks that you learned over the years for third molar removal, getting the speed down. What are some changes you learned in the last few years that really kind of added to your sequence? Because obviously that makes it less invasive potentially. Minimize the time, minimize the swelling in the end.
Yeah, I mean, some small ones that come to mind, like, so I have my assistants, once we're putting the meds and they're being sedated. This is after we do our timeout, of course. We always do timeout. But yeah, so once they're basically sedated here and they're falling asleep. The patient puts the bite block, or sorry, the assistant puts the bite block on the left. I don't move the bite block. I just inject all around it. So I inject the right side, then I go left side around the bite block. Then, the assistant does throat pack. I do incision on number one site, and they're just handing me, like scalpel pass. They know periosteal, next one, big straight elevator or whatever elevators we're using. Remove that one, and then we go straight to number 32. And I make a smaller incision, like a smaller buckle hockey stick. Residency, I think you need to make a larger one. And you know how in residency they want you to flap a big flap, and you want your Minnesota like all the way down, so you could let go of Minnesota and still like wedged in there on the side of the mandible. But like, I got to the point where I'm like, the more you create these big pockets like that in the gingiva and the mucosa, it's just the more likely they are to swell, to get infection, for stuff to get trapped in there. The healing takes longer. So, I just reflect, gosh, 4 or 5 millimeters, away, just enough to see the bone so I can trough without cutting any tissue with my burr. For their standard thirds, I use the 703 burr, which is a little wider, or a 702 if they're a smaller person. It's basically just buckle trough real quick, section, elevate the distal crown, distal root out, mesial crown, mesial root, put the PRF clot, suture, switch, bite block. And I've talked about this on the podcast, but I've had these back pains over the years. And so now I sit and I switch sides. So I'll roll over, I sit in a saddle chair, and I go to the left side to take out the left-sided teeth always.
Oh, you go to the left side. Okay. I didn't expect you to say that. All right.
Yeah.
Huh.
So, it's very awkward at first doing that, but after you do it for a couple months, you get the hang of it. It's so much better for your posture, like in your career, as far as ergonomics go, to switch and go to the left side if you're a right-handed doc. And then it only takes a second now, maybe 2 or 3 seconds to switch to the left. Just basically repeat the whole process over again. And then basically waking the patient up. I mentioned on one of my podcasts that I'm fairly quick to, if they're not waking up fairly quickly, like within a couple minutes sometimes, I'm pretty quick to give them some reversal and use flumazenil and wake them up. And the reason for that is, one, so their maybe recovery time's a little quicker. I think there's multiple reasons, but two, that we're very familiar with giving reversal, because I think that as I've studied and podcasted on many, many cases that have gone bad, anesthesia cases, one of the top things that recurs in cases where there's like a major complication is failure to give reversal. And I think the failure to give reversal is because people are rarely giving it, and assistants don't even know what it is. They don't even know there is a reversal, and doctors have it buried away in somewhere where they never see it, and now they look for it and they find it, it's expired.
What's the equivalent? What's the dose?
Yeah, exactly.
Great point. That's a really good point. So you reverse, like maybe towards the end of the case. Sometimes, like how often in a week, say that you end up reversing a patient?
I would say at least 2 or 3 times a week. If we're watching them 5 to 10 minutes later, they're pretty sleepy. We're tapping them, hey, open your eyes, and they're pretty groggy. We'll reverse them and give them 2 to 3 cc's of flumazenil, and 30 seconds later, their eyes are awake. They're following commands. It's a cool thing. I know there's the concern is resedation and things like that. I just don't see that.
You haven't experienced it much, huh?
No, I think that could be a thing if you're giving like a lot of Versed or, benzos, like maybe 15 or 20 milligrams of like Versed. And then if you did that much and then maybe you hit them with 2 or 3 of flumazenil, and then look, they're awake, and then you walked out, I could see them potentially resedating like after a couple minutes. Yeah. But if you're giving them 5 milligrams, let's say total of Versed, and you reverse them with 2 or 3 cc's of flumazenil, I never see them resedate. It's just a magical thing. And I just feel so strongly that everyone in the office who helps me should know that there is a reversal, know where it is, know that how to draw it up, because that's just another key to make sure that any anesthesia complications are taken care of very quickly and smoothly.
Yeah.
So, anyways, it's another nugget.
Yeah. Hey, this is really good. We're getting to some good meat and potatoes here for oral surgery, but bread and butter oral surgery practice. Tell me more about this incision design. You mentioned the hockey stick. Is your hockey stick that distal buccal release, or are you talking about the anterior, the mesial hockey stick, where you go down into the vestibule and a little bit forward anteriorly?
Yeah, yeah. So I do distal, like off the distal ridge where the wisdom tooth is, mid crestal. Let's say the wisdom tooth is buried completely.
Yeah. Yeah.
So distal hockey stick, mid crestal, and then I go to the back of the second molar, and then I wrap around just to the buccal, mid buccal of second molar, and no further. And then I reflect, that flap, whatever, 4 or 5 millimeters down, so I can kind of see the bone, see where I'm looking. And I'm really trying not to create like a flap that's like a big space, like on the buccal.
Hmm.
But it's like a balance. You're trying to create enough space so that you can trough without cutting into your soft tissue. And then it's basically just uncovering the top, painting, and things like that. I mean, I know people extend that mesial incision like to sometimes the papilla between the first and second molar. I know people who do like a mesial releasing incision, and I think that's fine. You probably have to, if you do a releasing incision, you have to suture it up, and it just takes more time. But I just don't. Rarely do I ever need to extend it past the mesial, past the mid buccal of the second molar, and I'm not like stretching the crap out of the flap or anything.
Yeah, that's my next question. Does it ever tear at all on that mesial portion? But no, you're not experiencing that.
Super rare, yeah, yeah. Usually not.
With the
Trying to think.
periosteal and you're reflecting the flap on the buccal, say we're looking at 32 and you're reflecting it towards the buccal, do you go up on the lingual side at all? Do you reflect that up at all? Or you're just drilling. You're drilling from the buccal immediately.
Yeah, I do take my periosteal and I go into that lingual and I kind of like put the periosteal in there and almost like lift up the periosteal so it kind of pries the lingual back to some degree. Yeah, I definitely do that. Sometimes too, if it's like like let's say you've troughed and now that you're elevating the tooth, you can kind of see this 32 getting impinged by the lingual tissue. I'll quickly like take my periosteal, put it in the lingual tissue, have my assistant like hold it towards them, so towards the tongue,
Yeah.
and then I re-elevate while they're holding it to allow the tooth to be elevated without having the lingual flap impeding it. I mean, I'm sure you do some similar stuff.
Yeah, basically same thing. What about what handpiece you're using? I got a contra angle, or at least do you prefer contra angle, straight handpiece? Have you tried both? What were you using day to day?
Yeah, I've tried both. I just do the straight KLS, 1 to 2. Those to me are just so great. I don't know why I love it. I've tried doing the contra angle. I know I have friends who do it all the time and they love it and they feel better with that. But for one reason or another, I just feel more comfortable using the straight B&Air KLS handpiece,
Yeah.
just on an electric motor. I was trained using the Hall drill in Chicago. It's a big thing, it drapes over your shoulder, the big hose, and it sounds like you're literally changing a tire in someone's mouth. It's so loud. It's like air driven. It's like, Wing! My goodness, we would do that under local, and people like your whole brain is like chattering around, and like, my gosh, I don't know how those patients did that, but it's just extreme power. That's the beauty of the Hall drills is so much power. But the problem is it's almost too much power. You lose tactile sensation sometimes. So
Yeah.
I really do love the B&Air. It's really nice.
Maybe I haven't checked that one out. I know some people that have recommended that. I'll have to look into that one. But I
Yeah,
remember the Hall drill. The problem is that you gotta fill it with diesel every couple of days.
right.
But yeah, it blows through bone. Like it's definitely powerful.
Oh yeah, for sure.
But
All right, like what kind of contra angle do you use?
It's basically just like a high speed, like a high speed that the GP uses.
Yeah.
It's just like
Okay.
one of those. But you know what I notice about the straight hand pieces? I think it splits, it sections the tooth better. And why is that so important? Because say, with the contraangle, I feel like the burr is not. Maybe I was using a wider burr. I don't think so though. But the split, the section when you cut it, it's a little bit wider because it's not holding it firm. I feel like the straight handpiece holds it in the right place so that when you put your elevator in there, you get a better split. That's what I'm trying to say. Versus
Yeah.
sometimes the cut is so wide with the contrangle, at least the one I was using, it's like at some when it goes really bad, it's the elevator's just spinning inside the tooth, and you're like, what
Yeah.
the hell? And now you're wasting
Yeah.
time. Now you got to do deeper. It's I always thought during residency, because we only had straight hand pieces in residency, I always thought that the contra angle was going to be the end all be all, and it really helps for disto-angular impactions, I would say, right? But for mesial impactions, mesial-angular, I would say the straight handpiece is advantageous because it's straight. You just hemisect it, flick the distal out, and then the mesial up and out. Basically, how you described, and I find that that's better. But it would be cool to have both in a practice, right?
For sure. Yeah. Yeah. I mean, because we use a regular dental chair, and so we have the high speed and all that available. And I occasionally will have to section a bridge or do stuff like
Mm.
that with the high speed. But yeah, I just keep going back to the straight BNRs and they're so annoyingly expensive. And I mean, I look on eBay for these. I'll sometimes find deals, but it's no. I mean, they're like $3,000 a pop each one. And it's just very frustrating.
Pacific's gotta get you with someone though. You gotta
Right?
hook
That's
you
what I
up.
keep saying.
Where's the, you know what? We should call up BNA or Chaos, whichever one, and get them, to sponsor your podcast or something. That's actually an idea.
They have been a sponsor in the past. Yeah, for a couple of years we had an agreement, and
What happened?
they, yeah, they sponsored them. I did commercials, all that stuff. It was fun. We ended up just kind of parting ways, but I mean, it was a good arrangement while it worked. Still, though, even then, as my sponsor, I had to buy the BNR. There's no love
What?
there. Yeah, they know how much people want those, so they're like, "Sorry, man, you got to buy that thing because that's high demand."
I'll tell you what, we're gonna one of these, whether it's a handpiece or a headlight or a new instrument. I want to partner with you on it, and it's just ours. Then we
That's
could
right.
take over BNR. We could take over designs for vision and oroscopic and all in one at a time. That'd be fun. That would be because
Yeah,
these people are so used to the monopoly that they've had for 50 plus years. It's gotta let the little
for sure.
guys in. But no, that's awesome. What's your favorite procedure to do? Say in the office setting, you see this and you're like, all right, it's going to be a good day.
Oh gosh. I mean, I honestly do love the third molars on a teenager. I love implants. I've really feel like I've gotten good, and we had excellent training with implants, sinus lifts, all that stuff with at UIC in Chicago. I was blessed there because I've been an attending here at the Denver Health Program, and I did that for a while, and that was super fun. I loved being attending, but their program isn't associated with the dental school. And
Hmm.
so when you're separate from the dental school, it's just much harder to get implant cases. And that opened my eyes, like how lucky I was to be part of a program where the residents would end up, over 4 years, we'd end up doing like multiples of hundreds of implants. Sometimes where you're at a program where they're not associated with a dental school, you're lucky sometimes if you get 20 or 30 or those numbers. Anyhow, all that to say, I love doing implants. Love full mouth extractions with all on fours, all that type of stuff. It's just so fun.
Yeah, I agree. Along the same lines, I find all those cases to be a lot of fun. For anterior implants, quick question: Do you
Yeah,
do immediates or do you always bone graft beforehand? Do you have a protocol there?
I mean we're always trying to do the immediate implant. I mean if it's a single rooted tooth, I'd say 90% of the time we do an immediate. I mean there are some contraindications, right? If there's an active infection, if there's a big, periapical radiolucency, there's just bad bone, all that type of stuff, wouldn't do it. But the majority, yeah, we'll take the tooth out and do an immediate. Usually, I mean, over the years, I've evolved to sinking my implants lower. I think the normal resident tries to put them crestal, and I'm doing like 3 or 4 millimeters at least subcrestal.
3 to 4 millimeters. Really? That much?
Yeah,
Oh wow, wow, yeah.
for sure. Yeah, I've just seen too many, aspects, especially in the anterior. I think it's always better to go a little deeper than you're thinking than not, because if it's too shallow, they're showing, gray in the gingiva. I mean, it's a nightmare restoratively to come back from an implant that's not deep enough. But we were taught, like, so you take a line, between the adjacent CEJs. If you were to put a line, let's say you're doing number 8, so you connect the CEJ from 7 to 9.
Mhm.
If there's a line connecting those CEJs, you'd want to go usually about 3 millimeters superior to that. Anyhow, we do Nobel. Actives are the main ones we use: Nobel Active, Nobel Parallel, Replace. And Nobel came out with these new healing abutments recently. They're kind of meant so that you don't have to remove too much bone to put
Hmm.
the healing abutment on. And I guess there's just more research showing the lower amount of bone you can remove um, around the implant, it's just the better it is for the long term prognosis of the crown. Have you experienced this?
Yeah, the less bone removal, the better. I like 3 to 4 millimeters, very deep though. I usually try to go like between 1 and 3, probably on average like 2 millimeters below the bone. But
Yeah.
I like that implant system. Straumann or Nobel are my preference. But yeah, everything
Yeah.
that you mentioned, I like that. Are you always putting abutments on it when you place the implant, or do you usually do cover screw, close it all up?
Almost always abutment.
Hmm.
Yeah. Even if there's a flipper or like a partial, we'll put a low profile abutment, anything to decrease the amount of cutting and drilling away bone later,
Yeah,
so we have a quick access. But yeah, how about you? Do you do healing abutments mostly, or
I try
cover
to.
screw?
Yeah, I mean, unless
Yeah,
it's like less than 15 to 20 newtons per centimeter, then I'll put the cover screw on. But otherwise, I really try and get that abutment on, and they usually go well. I mean, I've less experience than you, but yeah.
yeah.
Yeah. What about when you do cover it up? What's your favorite suture? Obviously, chromic 3.0 for wisdom teeth. Maybe you use 4.0 sometimes too. What about for, say you're taking out the tooth, you're extracting, and then bone grafting? What suture you use for that? Oh wait, it looks like you got muted. Want me to unmute? There you go. There you go. Unmute.
um, yeah, yeah. Usually we do a 3.0 or 4.0 chromic. I mean, occasionally, if we're really worried about some issue with inflammation, or the patient has said, "Oh, I get really inflamed with bone grafts" or whatever, then we would do something non-resorbable that's nicer, potentially like cytoplast or
Hmm.
nylon, but that's pretty rare.
Oh, that sounds
Do you
pretty
do
good.
chromic, or what are you doing?
For bone grafting, where I want to like try and stay in closer to 2 weeks, I've been doing monocryl with like a figure of eight and then a second stitch right in between the other two, like mesial. Oh, it stopped recording. It just started again. You're good. Wait, now it muted again. There you go. There you go. What's going on over there?
I don't know. Somehow my iPhone got. I'm using my Mac, so it like picked up all the volume and whatnot. Gotta
That's
love
all good.
technology. I think we're back.
That's all good. But yeah, we're at about an hour. So hey, I mean, we did a great one. We got a lot of insight. Got your background. Where you came from, where you're going. And like this is a lot of fun, and I'd be happy to hear. You said you're talking over a lot of things with your brother. If you're ever to make a switch, a move as far as like where you're at now at Pacific, I'd be interested to hear about that. I'd really like to know what your thoughts are
Yeah,
with
for
him.
sure.
Because you said you guys are both creative and idea people. I love to just to learn from that. So
Yeah, love to jump back on sometime. But yeah, we'll keep you posted. Our big push right now is our everyday oral surgery website.
mm,
Is we're making it like the ultra forum based place where surgeons can log in there and talk and share cases, and we got blog posts and just a just a ton of good community discussions happening there.
mm.
You can search the podcast much easier in there. So you could like, it's just so hard to when you have like hundreds of podcasts to search through that on iTunes or something. So on the website, you could just click easily. Okay, I want to look. What are all the podcasts that have been done on implants or pathology or whatever it is? So TMJ, it's all there. It's really nicely set up.
That does sound awesome. Like a database where you can quickly search through. That's a great
Yeah,
idea.
yeah, or by name too. Oh, I remember this, lecture that Dr. Marks gave or Dr. Maloro or so on. So it's just much easier than you can do it online. I mean, you could probably find a lot of them just Googling or Chat GPT, but the website is really helpful. So that's what we're doing lately.
Awesome. Awesome. So that's just everydayoralsurgery.com or .org.
Yeah, everydayallsurgery.com.
Excellent. So this way viewers and listeners can sign on to that and obviously give the podcast a follow, a
For
subscription.
sure.
So do you only post it in audio? Do you post it video? Do you post it on YouTube? You do, but do you on YouTube as well? I don't remember seeing you on YouTube.
No, we basically just do the audio and then we post smaller clips of the video on social media.
Yeah.
So yeah, there's just enough of our guests that don't, I don't know, that for some reason or another they don't want us posting the video, that we just stick with the audio.
Wow.
I think there's people who, I mean, oral surgeons, right? They always want to be looking and seen to be very professional, and so a lot of them will log in on their hoodie, on a podcast, and they're like, "You're not going to put the video online, right?" And I'm like, "Okay, no, we'll just do audio."
Oh.
Yeah, exactly.
Well, I guess you got to do that. No, it's good to see. I think it adds another dimension to engagement with the viewer or listener on that.
Yes, for
I think
sure.
it's a great idea to do. But yeah,
Yeah.
you should be posted on YouTube as well, at least when you can. I only had one podcast where they said don't put up the
The
visual. All
video.
the other hundreds have been. So that's interesting. But I do know what you're talking about.
Yeah. Well, maybe I'll try to do another push and see if we can get. I bet there will be more people that would, if I push them a little bit, would say, okay, yeah. They just would have to put on a nicer shirt and kind of prepare for video,
Yeah,
but
yeah.
not too bad.
What's when you select people to have on the podcast? When you select people like to kind of is it topic based and then you find someone by the topic, or is it person based and then you select a topic based on who that person is? Does that make sense?
Yeah, I think it's both, but I mean, at first I was doing a lot of groundwork the first year or two. I would just find people all over the place, emailing chairman, residency people,
Mm,
talking to friends. I found a lot of people through Amos Today, just reading the articles in there. But now, with so many people listening and following, it's almost a daily thing where people are emailing me saying, hey, I listened to this podcast. I think so and so would be another good person, and I'll put you in touch with them. So it's almost like my listeners do all of the finding work for me, or the bulk of it.
that's
And
awesome.
they kind of just hand deliver them to me and introduce me. And so I just ride that wave mostly because I got to take care of my 6 kids, so I can't be pounding the pavement too often. But
Yeah, dude, that's nice. I mean, and you're building community with that too. I bet if you were to give them like a coffee mug or a sweatshirt or a scrub cap or something, just to like, hey, you got in touch with 5 podcast guests that were excellent this year. I'm sending you a sweatshirt if you. I don't know. I'm not telling you what to do, but I think that marketing it would be great for your brand and it would make
oh,
a
same,
so. But
yeah, I really agree.
anyway, hey, why don't I hit end here and then you wanted to hit the other link or do we still have time?
Um, I would say let's plan that for a couple weeks from now. Maybe we come with a little outline, just because I got my son. He's texting me. Of course, I already have to take him somewhere.
You got it.
Um,
I understand.
so is that okay if we do a couple weeks from now?
Absolutely. You got it. You let me know. Let me know. Pick a date. Weekdays are usually better than weekends for me, but you let me know. Thanks for coming
Yeah.
on tonight, Dr. Stucki.
I appreciate you. Thanks for running through this. It's so nice of you to have me as a guest. It's awesome to be a guest instead of the host, and this is relaxing for me. It's fun.
Good, good. You got to
Yeah.
relax once in a while.
Yes. But yeah, great to connect. Wish you the best in all you're doing, and let's reconnect and do another episode.
Thank you. Thank you. Likewise. Yeah, we'll chat in a couple weeks. Let's do it.
All right. Thanks, my man. Good talking.
You too. All right. Take care.
Okay, bye.